another is acquired. So this is an example of the तो ये वाला जो है हमारे पास that is Hashimoto thyroiditis. So this is an example of the acquired. This is example of acquired things. The acquired one, that is Hashimoto. If we talk about the congenital, so one we have the congenital hypothyroidism also. So read that also. Congenital hypothyroidism. For chat box, you need to just chat me on the Google group. Congenital hypothyroidism. So congenital hypothyroidisms, what we need to do? Setting up इसके. Congenital hypothyroidisms, normally it is like started at the 4th weeks. See, the first week जो mother जो है having the TSS, mother का thyroid properly work करता है, तो baby के अंदर hypothyroidism के symptoms नहीं आते हैं. In the first month, the mother TSS or mother thyroid hormones works, so that's why we will not get any features or any symptoms or in the baby itself. So mostly this congenital hypothyroidism, the hypothyroidisms, it started at the second week or it begins at 4th week. It begins at the 4th week. What is the most common cause? So most common cause you need to remember, that is the pituitary dysplasia. So if pituitary, also you can understand from here, the pituitary gland, we have the two type of the pituitary types. We have the anterior pituitary and we have the posterior pituitary. So in the anterior pituitary, yes, if pituitary dysplasia will be there, the anterior pituitary hormones will be decreased. So anterior pituitary hormones will be decreased. Because posterior pituitary, I told you that it is just release the hormone that is secreted by the hypothalamus. So it will not affect on the ADH, oxytocins. So that's why the anterior pituitary hormones will decrease. Okay. What is the most common cause? That is the pituitary dysplasia. Also remember this congenital hypothyroidism. This is the most common preventable cause of intellectual disability. The most common cause of intellectual disability. What is the intellectual disability? The intellectual disability is what? Mental retardation. Mental retardation is what? That is intellectual disability. See, if you are getting the questions, most common preventable cause of the intellectual disability, that is congenital hypothyroidisms. But what is the second most common? So write it here also. The second most common cause of congenital hyperthyroidisms, that is the second most common cause of mental retardations, that is again we having the Down's syndrome. Okay, write it there. So which is the most common preventable? We cannot prevent it, but Down syndromes, they cannot prevent it. The most common preventable cause of intellectual disability, that is the congenital hypothyroidisms. What are the other causes that can cause the congenital hypothyroidism? If the baby having the problem in the thyroid glands, if thyroid gland will not form, so will baby be able to form the hormones? No. So there is an anomaly of thyroid gland. There will be the anomaly of thyroid gland. The anomaly of the thyroid glands. Then after that we having the thyroid dishormogenesis. Thyroid dishormogenesis. What is the thyroid dishormogenesis? देखो, one thing is there, that anomaly of the thyroid gland means that is the thyroid dysgenesis. We call this condition as the thyroid dysgenesis. Can I write it? Thyroid dysgenesis. What is the thyroid dysgenesis? There is no formations or very less formation of the thyroid gland, due to which the thyroid gland will not work. If thyroid dishormogenesis means thyroid is there but hormones are not working properly. There is a problem in the functioning of the hormones. So that is the thyroid dishormogenesis. Or what can be the other cause? The other cause can be the iodine deficiency. Iodine deficiency can be there. If iodine deficiency will be there, Yes, that can these patients can having the uh, congenital, that patients can having the hypothyroidism, because iodine they help in the organifications. Okay, like T3, T4, all these things will be made with the help of MIT, that is monoiodothyronine, then diiodothyronine. When two diiodothyronine combines, they form the T4 hormones. When one monoiodothyronine or one monoiodothyronine plus two DIT will be formed, so they will form the T3 hormones. So that's it becomes the T3 and T4 hormones. So if iodine deficiency will be there, of course there will be the hypothyroidism. This you need to remember till here. After that you need to remember, see, there is a one thing that when we talk about the features of the congenital hypothyroidism, so first week I told you that there is a asymptomatic conditions. The first week, if we talk about the clinical feature, what are the clinical features? What will be the clinical feature? The clinical features that we see in these patients, so what will be there? That is the first week will be the asymptomatic. The first week will be the asymptomatic phase. Asymptomatic phase will be there. That will be the asymptomatic. Then in after the like first week, after the I told you after the for mainly the first weeks, or I told you that it begins at the fourth week. So after like around the fourth week, we can say the symptoms can started. And what type of the symptoms? The person will be having the decreased activity. The person having the decreased activity. The persons will become the lethargic. The person will become the lethargics, or the baby neonate will become the lethargics. Then there will be the hypothermia. I hope every one of you know already that thyroid gland they help in maintaining the BMR. Thyroid gland they help in maintaining the basal metabolic rate. They help in maintaining the basal's metabolic rate. Whenever we go to the any colder countries, the thyroid glands will develop to like maintain the temperature. So that it cause the hypothermia. It will cause the hypothermia will be there. If low thyroid gland, hypothermia will be there, and the persons will having the cold. After that, there can be the delayed passage in meconium. There will be the delayed passage in meconium. The delayed passage in meconium, we called this condition as the constipation. We called it as the constipation. So delayed passage in meconium, we called it as the constipation. Then there will be the coarse phases. The coarse phases, this is also seen in conditions like the facies or the purple stria. So this is also seen in the case of the Cushing syndromes. Someone asked me today questions today, so that was seen by purple stria, purple, or mainly the stria, muscle stria, that is due to muscle stretching. So that will be seen in case of the coarse facies, moon-like faces. So this is seen in case of the Cushing syndromes. Here we can see the coarse faces. Along with that, we can see there will the hoarse cry. There will be the hoarse cry will be there. The baby will be having macroglacia. What is the macroglacia? Large tongue will be there. The baby will be having the large tongues. Then will be having the prolonged jaundice. There will be the prolonged jaundice will be there, and like prolonged jaundice like more than 2 weeks after the birth. There will be can be the umbilical hernia can be the possibles. Umbilical hernia can be possibles, and there can be the like whatever the goiter, there will be the no goiter. So no goiter will be case in case of congenital hypothyroidisms. Okay. After that, after that you need to remember ki how if you will do the investigations. This is what investigations. So we will do the thyroid function test. So we will do the thyroid function test. What is that? Thyroid function test. So in case of the thyroid function test, what it do? There will be the decrease in T3 and T4. So if there will be the decrease in T3 and T4, so tell me if there is a decrease, there will be the feedback going to the pituitary, and then pituitary will be having the thyroid stimulating hormones. So what they will do? They will increase the thyroid stimulating hormones, but that will increase the thyroid stimulating hormones. So this profile will be seen, decrease in the T3 and T4 hormones. Along with that, we can see that there will be the increase in the TSH hormones. But like again, if we having the, when we do the TFT, we will do around the fourth to fifth day, because fourth day or the fourth to fifth day after the birth. Why should not do like just after the birth? Because after the birth, mother TSH is high, and due to which the baby TSH can be the high. Usually this is the physiological conditions. In every baby we will see that there is increase in the TSH levels. Why? Because of the mother thyroid gland, or mother thyroid profiles, we can say. So this was what? That is the congenital hypothyroidism. So that you need to remember. After that, see, like we have the questions here. This one, question number 122. A 2-month-old child with the birth weight 5 kg has jaundice, horse cry, umbilical hernia. So there is a horse cry is there. Along with that, there is a umbilical hernia, physical developmental lag, liver is 2 cm, spleen is not enlarged, delayed falling of the umbilical cord rest. So delayed falling away of the umbilical cord rest, that we can see. There is a delayed falling away of the umbilical cord. In the blood, we can see hemoglobin, erythrocyte, ESR, whole serum, bilirubin, direct. So they have the indirect, bilirubin is more, direct is less. What is the most probable diagnosis? So we can say that patient having the jaundice is there, horse cry is there, umbilical hernia, physical developmental lag. So these all going to the make the diagnosis of the congenital hyper. Delayed falling away of the umbilical cords. So delayed umbilical cord or delayed cord clamping can be seen. So that all can characterize the congenital hypothyroidism. Okay. Other, you already know that there is hemolytic anemia, cytomegalovirus. In the cytomegalovirus, you will see the owl's eye appearance. What type of appearance? Owl's eye appearance. Okay, if they will give you question directly like from here till here, can it be the conjugated? Of course, no. It can be the indirect is more, so it most probably, if it will be there, that will be the unconjugated. Congenital hepatitis, that is also not the case in these conditions. Okay, so let's come back. After that, we having the question number 119. See, a 5-year-old child with the stigma of dysembryogenesis, small chin, thick lips, open mouth, has systolic murmur in the second intercostals. So see, I told you that there is a systolic murmur where in the second intercostal to the right of the sternum. So tell me, second intercostal space, what we heard? All people eat Turkish meal. All people eat Turkish meal. Okay, so all means we having the aorta. All means aortic sound. So aorta will be here at the second intercostal space. Then we having the P4, we having the pulmonary aorta, pulmonary artery, sorry, that is the second intercostal space. Then E4 we having the Ubbs point. E4 we having the Ubbs point. T4 we having the tricuspid. T4 we will be having the tricuspid wall, and M4 we having the mitral valves. M4 we having the mitral valves. So we can consider it will be at the third intercostal, fourth intercostal space, and it will be here at the fifth intercostal space. So here you can see that the second intercostal space can be having the aorta, or maybe there can be the pulmonary. So there is systolic murmur in the second intercostal to the right of the sternum. So right of the sternum, what we will hear? Yes, right of the sternum we having the right of the sternum, what we having? Aorta, because aorta passes like this, pulmonary aorta going like this, so it will be on the left sides and this will be present on the right side. So aortic sides on the right and this pulmonary will be on the left. The murmur passes to the neck and along the sternum left wedge. The pulse on the left brachial artery is weakened. So we can see that pulse on the left arterial is weakened. I hope where I told you the Steele syndromes, where I told you the Steele syndrome. So there I make a diagram about like how the ascending aorta, then subclavian artery, brachiocephalic trunks, and all those things like they. So after that brachial artery will be there, axillary artery, and after that axillary artery we will see there is a brachial artery. So the pulse on the left brachial artery is weakened. BP on the right arm is 110 and left is 1. So you can say that okay, there is a some murmur is there. The most probable there is again hypertrophy of the right ventricles, hypertrophy of the right ventricles. So can we say that this can be the condition of the aortic stenosis? Why aortic stenosis? Because we are hearing the murmur at what level? Second intercostal space, and we know that at the second intercostal space there will be the aorta is present, so it will cause the aortic stenosis. Okay. Other than don't worry about like the aortic stenosis, pulmonary stenosis. We will study it once more time when we will discuss the cardiology. For now, you need to understand the stenosis means there is a narrowing will be there. The stenosis means narrowing conditions. So if the aorta that will be the narrow, so it will lead the less supply, and due to which we will see there is a left brachial artery will be the weakened. The pulse will be weak on the left brachial artery due to aortic stenosis, or any pathway that is going to the brachial artery. If it is stenosis, there will be the less pulse will be here, or less pulse will be felt on that side. Okay, that is this main concern or the main keyword is here, that is the systolic murmur where in the second intercostal space to the right of the sternums. Correctation of aorta we already discussed. Open aortic ducts we already discussed. The defect in open aortic ducts or the patent ductal arteriosus, we studied that there will be the machine like murmurs. Defect of interventricular septum we already discussed. Then after that, come back to the question number 120. See, a 1 to 5-year-old child fell ill acutely with the high temperature 38 degrees Celsius. There is a headache, fatigue, there is a fatigue. The temperature declined on the 5th day. Muscular pain. So you can remember from here that if any like condition of the poliomyelitis, in the poliomyelitis when the temperature declined, that decline on the 5th day, muscular pain in the right leg occurred in the morning. There is no movement and tendon reflex. So these are the no movement or the decreased tendon reflex. So these all are the feature of the lower motor neuron lesion. These are the feature of the lower motor neuron lesions. Sensitivity was what is the initial diagnosis. So we have this here, that is the poliomyelitis. So let's discuss what is poliomyelitis. See, when we discuss about the poliomyelitis or the poliomyelitis or the polio infections, poliomyelitis, or we can say the polio infection. See, first that we need to understand, if any poliomyelitis or the polio infection is there, it is caused by the picorna virus. It is caused by the, there was one question already, that was it is caused by the picorna virus family. Then the second thing, remember, this is transmitted through fecal route. This is transmitted through which route? Fecal route. The transmitted the feco, or we can remember feco-oral route. Feco-oral route means we can say by like water, that is infected water. So fecal-oral route, they transmitted through the fecal routes. These polio infections, they will through the fecal-oral route, they enter into the bloods. They enter into the bloods. In the blood, we having some, it will cause the like it is we having the picorna virus. So it will cause the viremia. What is the viremia? Virus in blood. Virus in blood. So we call this condition as the viremia. If bacteria in the blood, we call this condition as the bacteremia. So in blood we having the viremia, and from the blood it will transmit it to the central nervous systems. It will transmit to the central nervous systems via peripheral nerves. Via the peripheral nerves. So what they will do there? Why they are going there? See, first of all, they will finally reaching the, after the CNS, they will reach to the anterior horn cell of the anterior horn cell in spinal cords. So in the spinal cord, we have the anterior horn or the posterior horns. Spinal cord. In the anterior spinal cord, we having the anterior horns and we have the posterior horns. So if the anterior horn cell in the spinal cord, they will be affected. So they will cause their acute flaccid paralysis. They will cause what? Acute flaccid paralysis. Acute flaccid paralysis. And flaccid paralysis, I hope you know that we having the two type of the lesions. We have the upper motor neuron lesions and we having the lower motor neuron lesions. If we having the central, in upper motor neuron lesions, we having the central paralysis. We having the central paralysis. In lower motor neuron regions, we having the peripheral paralysis. What we having the peripheral paralysis, and we can also call that there can be the flaccid paralysis. There can be the flaccid paralysis. So there the peripheral paralysis and there will be the flaccid paralysis will be there. Okay, there will be, you see, there is increased tone. There will be the increase the tones, increase reflex. So everything will be increased here. But in this, if you have the lower motor neuron lesions, there will be the decrease in the tone of the muscles. There is a decrease in the reflex. Okay, so that you need to remember. And here in the flaccid paralysis, so there will be the, we will see there include the, there will be the like weakness. Along with that, you can see that there is a lower motor neuron symptoms will be there. Lower motor neurons lesion symptoms will be there. So like there is a hypotonia or hyporeflexia. So all these things will be there. And also remember the incubation period of the poliovirus. If we talk about the incubation period, then incubation period, remember, it is 8 to 12 days. It is 8 to 12 days. Incubation period is 8 to 12 days. So in the blood, it will go to the from the blood it will go and it will cause a viremia. From the blood it will go to via the peripheral nerves. It will go to the central nervous systems. From the central nervous systems, it will comes to the lower, through the lower motor neurons. It comes to the anterior horn cell in the spinal cord, and they will cause the acute flaccid paralysis, lower motor neuron symptoms. So like there is a decrease in the, there will be the decrease in muscle tone, the decrease in the muscle tone, the decrease in the reflex. So everything will be decreased. So this type of the symptoms will be seen. So that you need to remember. The anterior, can we also remember the anterior? We can also call it as the ventral. The posterior we can also call it as the dorsal. So there is a ventral horn or the anterior horn cells. So this will be the main that will be damaged in case of the poliomyelitis. So poliomyelitis, you need to remember that it is caused by the picorna virus. It is caused by the picorna virus. Then after that, they affect the ventral or the, they affect the ventral and the anterior horn cell in the spinal cords. What they cause? They cause the flaccid paralysis, or can also call it the peripheral paralysis. They can flaccid paralysis, or they can also call the peripheral. We can also call this condition as the peripheral paralysis. So weakness and the lower motor neuron symptom, there is a decrease in the muscle tone, decrease in the reflex. So that you need to understand. This is what poliomyelitis. Okay, so there is a no movement, high temperature is there, headache, of course the high temperature will be there, headache will be there, fatigueness or the weakness will be there, muscular pain in the right leg occurred in the mornings. Yes, the pain will be there due to weakness and all those things, due to decrease in the muscle tone, decrease in the reflexes, no movement, and there is a decrease in the tendon reflex. See, if we have seen the poliomyelitis, we see in we have in the lower motor neuron lesions that we seen in the poliomyelitis. But if we specially talk about the poliomyelitis, there will be the more damage in the lower motor neurons, or you can say the lower motor neurons, they completely not working at all. So that's why there will be no movement and there is a no tendon reflex will be seen. Okay, so you are getting any this type of the questions. After that, you can get asking about the what is the cause of poliomyelitis, that is the picornavirus. You can be asked that if during the question there can give you something anterior rami of the spinal cord or the ventral rami of the spinal cord is affected. Then they ask you the virus. They can ask you the directly the diagnosis. So that will be the poliomyelitis. Okay, done, done. I hope this is clear. Then let's do the next question. A 3-year-old child has been delivered to the hospital in the soporose state. What is the soporose state? See, we having one is coma state. One is what? Coma state. The person is going get onto the coma. And soporose is what? That is the person is going into not in the coma but like a mild state, and in which person having the abnormally deep sleep. The person having the abnormally deep sleep will be there. With considerable amyotonia. Amyotonia, from the terminology, A means absent, myo means muscle, stone means muscle stone. So muscle stones will be absent. Inhibition of the tendon and periosteal reflexes, yes. Meiosis and asthenochoria are also present. Corneal reflex are features. Pulse is rapid and weak. The parents suspect the child of accidentally taking the, there is a 3-year-old child, okay, 3-year-old child having these symptoms and is accidentally taking the some tablets. Such clinical presentations are typical for intoxications with the following tableted drugs. So this type of the conditions we see in the like the tranquilizers. What are the tranquilizers? Tranquilizer here, or you can see like in other condition also, but again for that you need to understand that you need to remember the, read the last line, and after that read the options. We need to select it from the given options. So we have the options, that is the tranquilizers, we having the beta 2 adrenoreceptor agonists, antihypertensive drugs, entropin drugs, or the barbiturates. So for this we having used the tranquilizer. What are the tranquilizers? The tranquilizer are the anxiolytic drugs. Anxiolytic drugs that help in the anxiety. They are also the antipsychotic drugs. They are also the antipsychotic drugs. They are also the mood stabilizers drugs. They are also the mood stabilizers drugs. So for treatment for the anxiety, fear, like any agitations or the disturbance, any mind, so in that conditions we will give these conditions. So if this can this is given in the like the children's or the accidentally taken the baby, the child accidentally taken these tranquilizers, they can having the symptoms of anxiety, anxiolytic symptoms, antipsychotic symptoms, or the mood stabilizers like abnormality or the we can overdosing symptoms can be seen in this children. Okay, after that we having the beta 2 adrenoreceptor agonist. You know what is the adrenoreceptors, antihypertensive drugs you also know, entropin drugs. Maybe it is atropine drugs. It is not entropin, it is the atropine drugs. And we having the barbiturates. Okay, this we already discussed. Like just I hope you are all are revising the Croc 1 notes. I told you the pharma, micro, and histology. Minimum these three. If you don't want to do the all the subjects, at least do these subjects. Just only the rapid revisions: pharma, micro, and histology. You can watch the video, you can watch the notes, but you need to do. Believe me, this will work. This will help. If they can give you the 2 marks also, that can be a key factor, or that the important things that you can go for. Not, but I hope like if they, because in the last papers they gave the many drugs in the question paper, so that's why I'm saying just revise all the previous drugs as well. Whatever the drugs will be here we will discuss, but you need to revise all those drugs again, whatever you revise already. or whatever you studied during your third year, just you need to recall those drugs. That is now in your subconscious mind. Now just you need to put that in your conscious mind. Okay, this type of the drugs, so I studied. That's it. Then we have the whitish deposition of the cheeks, mucous membranes, that Warthin Finkel-Day spots, that is a measles. This one we already discussed about the meningitis, everything we discussed. There is with a decrease in the sugar concentrations. Okay, the sugar concentration 2.2 millimoles. So all these we'll discuss. Just revise all the previous notes, and they will have the, if more than is 80% the neutrophils, so we having the bacterial conditions. So that we called it the purulent meningitis. We discuss everything like viral, fungal, all these things. Just revise everything again and again. Then we have the LE cells, that is seen in case of the systemic lupus erythematosus. LE cells is the lupus erythematosus cells. Okay. After that, acute pneumonia. This one we also discuss. Bronchography. See, if there is a, we can see that if 8-year-old boy complained of the constant cough along with the discharge of the greenish sputum. Dyspnea during the physical activity. At the age of 1 year and 8 months, he fell ill for the first time with the bilateral pneumonia that had protracted course. Now see the question. We having the constant cough. We are having the constant cough. There is a greenish sputum. Dyspnea during the physical activity at the age of 1 year with bilateral pneumonia that had protracted course. The D5 to recurrence is there, and during the remission period, that is the constant productive cough. The constant productive cough or these symptoms, like the patient having some things, the bronchitis kind of the problems that we discuss, the bronchitis. So if having the productive cough and cough with the sputum, there is a cough with sputum, so that is considered into the bronchitis. So any bronchial disease or any problem having the any problem in the obstructions, any problem having the inflammations of the bronchus regions or the bronchiolitis. So what we will do? We will do the bronchography. What we will do? We will do the bronchography. Bronchography, you can say this is the X-ray of what? Bronchus. The X-ray of the bronchus. Okay. So that is the, we will do the bronchography. We will not do the bronchoscopy. Bronchoscopy will be not done. What we will do, the bronchography. So please, this question already asked in your exam, so don't make this mistake. We have the both options, bronchoscopy and the bronchography, but don't type the broncho. But what the right correct answer you need to choose, that is the bronchography. What is the graphy? You can remember like the we have the X-ray, so roentgenography and bronchography. Roentgenography and bronchography. Okay. Okay, I hope till now everything is clear. Okay, let it be. Yeah. So we having the bronchography, that we will do X-ray of the bronchi. What is the difference between the bronchography and bronchoscopy? See, bronchoscopy is what, when we do the complete evaluations of like all the trachea, all the bronchi, all the bronchioles, so that we call it as a bronchoscopy. But in bronchoscopy we put a like flexible tubes like used like we do in endoscopy. I hope every one of you what is the endoscopy. So in endoscopy, what we use, we put the endotracheal tube, so that we will do take the images of that and we see the in the camera, and so that same like the we do the bronchoscopy. We will going here into the, and we are taking the bronchoscopy like with the help of any camera, and we are taking all the complete evaluations of the whole trachea, the bronchus, and everything will be covered. So in the bronchography, we are taking like something X-ray images of that. Okay, so we are taking in bronchoscopy, even remember we use like any flexible tubes, but in the bronchography we use the X-ray of the bronchus. Then gouty arthritis we already discussed. I think there was one more things. Okay, so there is a mother of 5-year-old girl consult doctor about the daughter's involuntary urination at the night. There is a nightmare, sleep disorder, slow gaining of the body weight. Objectively, there is a malnutrition. Intellectual development is good, and the girls can read and explain the common situations quite adultly. Her skin is very pale, liver is enlarged in the size. She suffers from the hololithiasis. What is hololithiasis? It is cololithiasis. It is not hololithiasis. It is cololithiasis. Cololithiasis. What type of the diathesis? So this we already discussed. The cololithiasis, the uric acid stones will be there. So that's why there will be the gouty diathesis. Just revise that things. What is the lymphohypoplastic diathesis? When the lymphohypoplastic, when we will call it lymphohypoplastics, if muscles is underdeveloped, muscles is underdeveloped. Muscles is underdeveloped, so we call it the lymphohypoplastic, and along with that we will see there will be the hyperplastic lymph nodules. There will be the hyperplasia of lymphatic nodules. Hyperplasia of the lymphatic nodules will be there. In case of exudative, the exudative was what? That is the like catheteral inflammations we studied. Catheteral, exudatives, all these things. So in the catheteral inflammations, or the we know that there will be the which membranes will be inflamed? The mucous membrane inflammations will be seen. The mucous membrane inflammation, so that is what? Exudative diathesis. It can be involved the like bronchial mucous membrane, so that can be the associated with the bronchial disease. The gouty diathesis, we studied that the uric acid or the cololithiasis, asthma, that is uric acid. Then we have the urine acid diathesis. Urine acid diathesis, there is nothing, and there is one more, that is the arthritic diathesis, nervous or the arthritic diathesis. So it is associated with like the patients having the obesity, nervous systems irritations. So all these things will be related to the arthritic diathesis. There can be the joint disease, mesenchymal disorder. All these things you will find in the questions. So they will just ask you directly the questions, which type of the diathesis is it. So that is again become the, like if you are having the questions, you are getting the cololithiasis or the uric acid stone, that is the gouty diathesis. If you are getting that like any mucous membrane is inflamed, so that you can consider it as the exudative diathesis. Urine acid diathesis, there is nothing, but that is a uric acid. There is one uric acid diathesis. Then we can having the nervous arthritic like obesity, nervous systems, joint disorders, mesenchymal, all these type of the diathesis will be there. And everything diathesis, what is the diathesis and what is like mainly we discuss there gouty arthritis, gouty diathesis. Now here you can remember all these other diathesis, lymphohypoplastic, exudatives, and arthritic, all these type of the diathesis. Then the next questions, what we will do. So a 10-year-old girl complains about the abdominal pain that is arising and getting worse after eating rough or spicy food. She complains also after eating rough or spicy food. So there is a eating the rough or spicy food. She complains also about the sore erection, heartburn is there. So heartburn we seen in case of like patient having the reflux disease. That we seen in case of the reflux disease. frequent constipation, headache, irritability. She has been suffering from this for 12 months. Objectively, the girl's diet is adequate. Tongue is moist with the white deposits at the roost. Abdomen soft, painful in what epigastric part. It's painful in the epigastric. What study method will help to make a diagnosis? So we can see that this is condition is seen like the we can having the reflux disease, and the reflux disease we know that is the seen in case of like the GERD patient. What is the GERD? Gastroesophageal reflux disease. The gastroesophageal reflux disease, in all those conditions we see that there is a this type of the conditions can be seen. So for the GERD, what we will do, just give me a second, I'm coming back. Okay, just give me 3 minutes. Okay, I'm sorry. Okay, so where we was? So there is a we can see that in this patient there is a sore irritations, like जिसको बोलते हैं खट्टापन आ रहा है, and heartburn. We having the reflux disorder is there. So what we having, the abdomen is soft and painful in its epigastric parts. So epigastric parts we having like the stomach, or there is a some the heartburn type of this thing. So we can see there is a pain, something will be there. So this is what, that is the GERD. GERD we having, that is the gastroesophageal reflux disease. Gastroesophageal reflux disease. Okay, so what is that? So let's discuss. We having the GERD, GERD disease, gastroesophageal reflux disease. So what happen in this condition? There will be the reflux of gastric content into the esophagus. There will be the reflux of gastric contents into esophagus. So that is what reflux disease into the esophagus. After that, you need to remember that if this when we talk about the children there will be the recurrent. This is like common in the children's, because whatever they will drink the milk, and that will be vomit outs. So that is cause of recurrent vomitings. So children's we will see there will be the recurrent vomitings, and these recurrent vomitings, that can be the reason of malnutrition in the GERD patients. There will be the malnutrition in GERD patients, and then can cause the baby will be having like severe malnutrition conditions, can be problems. Okay, and also there can be the complications, like if there are any children who is having the recurrent vomiting, so that vomiting he can aspirate it also through the trachea, that can cause the pneumonitis also in the children's. Okay, I hope till now this is clear. After that, you need to remember what are the clinical features that we seen in case of the in case of the GERD. So in case of the GERD, we see that there is like patient, if the patient is coming, there will be some acidity problems, and like the any adult persons or any patients, they will help, they will any factor that help in the like the problem in the intra abdominal esophagus, and there the problems like gastroesophageal angles will be deviated. So that we need to remember there in case of the GRD patient. So that one more reason of the GRD patient, when there will the recurrent or the continual reflux will be there. So this the gastric mucosa is irritating. So the gastric mucosa that will irritate the esophageal mucosa also, and that can also lead to the metaplasia that we seen in case of the Barrett's esophagus. I hope you all know what is the Barrett's esophagus. The Barrett's esophagus, the epithelial layer of the esophagus is changed. This is the one of the reason of the reason is the GERD. What other clinical features that we see in GERD patient persons, that is heartburn. We can see that one we already discussed, that is the heartburnings. We can also call this condition as the retrosternal burning sensation. We can also call this condition as the retrosternal burning sensations. And this is what the most common symptoms of GID. This is the most common symptom of GERD. The most common symptom of the GERD, that is the heartburn. Along with that, the patients can having the chronic cough. The patients can having the wheezing. The patients can having the dental caries due to recurrent vomiting. Dental caries can be there. There can be the pharyngitis. There can be the laryngitis. There can be the, we can see the like the persons will be having the bitter taste in the mouth. The bitter taste in the mouth, that can also be visions. So what investigations we will do in these conditions? We will do the investigation of the choice will be the, that is upper GI endoscopy. What we will do? The upper GI endoscopy. And if somebody will ask you what is the gold standard, what is the difference between the investigation of the choice and the gold standard? See, investigation of the choice that we used for our personal, like in that we can use, but gold standard is that if it is showing that this is the diagnosis, it means that it is 100% is what, that is the GERD, that is the gold. So that is the gold standard investigation, that accuracy will be the 100%. Investigation of the choice, that is like financially or economically, that is well we can see in every hospitals, that type of the conditions, that we do the upper GI endoscopy. But gold standard, that 100% accuracy, but we can't see in loads. We see it very rarely in very less hospitals. So we called it as the gold standard. But if it is characterized, or if it diagnosis, that means it is 100% accurate. So what is the gold standard diagnosis for the GERD? That is the 24 hours pH monitorings. That is the 24 hours pH monitorings will be there. Okay. So that you need to, that is the GERD for you. So what we study method will be how to make a diagnosis, that is the esophago gastroduodenoscopy or upper GI endoscopy. In simple terms, what I wrote, that is the upper GI endoscopy. Here what they wrote, upper GI means it include everything, esophagus, they also include the gastrinum, and they also can we can do the duodenoscopy as well. So esophago gastroduodenoscopy will be the answer. So upper GI endoscopy. Upper GI endoscopy will be the answer. Okay, I hope this is done, and 10 out of 10. ठीक है? After that, question number 131, a 40 what is that 40-month old child has hyperesthesia, CNS depression, or there is a dyspepsia. the sepsis is suspected. What should be the differential diagnosis be made with? See, the sepsis is there. The sepsis means that mainly it will be caused by, like, we're talking here about the neonatal sepsis. We are talking here about the neonatal sepsis. Here we are talking about the neonatal sepsis. Remember that if you're talking about the neonatal sepsis, that it can be caused by, like, mainly it is caused by the like if you talk about worldwide, it is caused by the gram positive or streptococcus bacteria. Then if you talk about India, that is caused by the Klebsiella. And also remember, this is the second most common. Okay, let me write it here only. The neonatal sepsis. Neonatal sepsis, it is the second most common cause of neonatal mortality. This is the second most common cause of neonatal mortality. Okay, the second most common cause of the neonatal mortality. Then what are the clinical features we will see? The neonatal sepsis, the clinical features of the sepsis will be seen. Along with that, see, this sepsis mainly we know that it is caused by the bacteria. So we will see there is a bacteria in the blood. So that conditions we call it is the bacteremia. So there will be the bacteremia in first month. There will be the bacteria in the first month. What the most common cause worldwide? The most common cause worldwide. The most common cause worldwide is the group beta hemolytic streptococcus bacteria. Group B hemolytic streptococcus bacteria. Streptococcus bacteria. If we talk about the India, what is that? Klebsiella. Klebsiella. The Klebsiella is the most common cause of the neonatal sepsis in India. Okay. The most common cause of neonatal sepsis in India is what? That is the Klebsiella. After that, what are the, like, if you talk about there is a neonatal sepsis, what are the early features we see, or other clinical features we see in these conditions? The first things that we do earliest, there will be the baby will be having the change in the feeding pattern. So there is altered feeding patterns will be there. And this baby will be the lethargic baby because he is not taking the feeding diet properly. So that's why it will become the lethargics. Then after that there will be the baby will be having the hypothermia. That will cause the fever. We can say the fever in the preterm baby. And after that we will be having the respiratory distress can be seen in case of the neonatal sepsis. Respiratory distress can be seen. And there can be the seizures can also be developed in case of the neonatal sepsis. Okay, so again for that we need to do the gold standard techniques. We need to check about the blood cultures, and if we will suspect the sepsis, we will start the IV antibiotics as soon as possible. Okay, that you need to remember. This is the second most common cause of the neonatal mortality. Okay, tell me which is the most common cause overall of neonatal mortality. The most common cause of neonatal the most common cause of the neonatal mortality overall, that is prematurity. That is the prematurity. So the second most common cause is the neonatal sepsis, and the most common cause overall is what? That is prematurity. That is the prematurity. Now see, if the neonatal sepsis is there, there will be the bacteremia. This bacteremia, they can go to the CNS also, and all other regions that can cause the seizures like problems. So if we can consider that if it is a bacterial problem, bacteria what they do? They love the glucose. Bacteria what they do? They love the glucose. So we have the differential diagnosis we need to find from the questions. So all these are not mentioned there. I told you all the meningitis, everything. So I told you that bacteria that loves the glucose. So that's why the sepsis, they can be differential diagnosis we can made, that is what hypoglycemia according to the questions. So what the diagnosis is, what that hypoglycemia, because the sepsis is there, the hypoglycemia can be the in case of the sepsis, hypoglycemia can be possible in the any patients. Okay, because bacteria they love to eat the glucose, and we will decrease, they will take the glucose as the energy source, and that's why there will be the decrease in the hypoglycemia, that will further increase the sepsis amount, because the bacteria will grow further and that will increase more, sepsis will be there. And there can be the hyperesthesia, there can be the serious depression, the dyspepsia. I told you, like the seizures like problems, there will be respiratory problems can be there, and the patients will be having the hypothermia. Okay. Then question number 135. See, 135 we know the thirst, polyuria, there is increased appetite for the 2 months with the weight loss of the 3 kg. There has been nocturnal enuresis during the last week. Hyperglycemia is there, and the diagnosis is the diabetes mellitus type 1. That's the easiest questions we got. So what is the diabetes mellitus? We know that it is what? It is the autoimmune conditions. It is the autoimmune conditions. The antibody will be formed against the beta cells, against the beta cell of pancreas. We know that in pancreas we having the alpha, beta and gamma cells, and if beta cells will antibody formed against the beta cell of the pancreas, so these beta cells what they do, release the insulin. So if the antibody will form against the beta cells, no insulin formations. If no insulin formation, the glucose will be increased, and that will cause the diabetes mellitus type 1. Okay, so this is the direct questions. What is the diabetes mellitus? So it is the autoimmune conditions. This question, a child, we will discuss it. Okay, let's read the question. A 10-year-old child who is an oligoanuretic stage of acute renal insufficiency has got sensation of pricking in the mucous membrane of oral cavity and tongue, extremities and numbness. There is a reduced reflexes, respiratory disturbance, or there is a arrhythmia. What are these symptoms caused by? See, this is caused by the hyperkalemia. So if any arrhythmia problems, if any problems in the arrhythmia like symptoms is there, so we know that can be the caused by the hyperkalemia, or that can be caused by the hypokalemia. Okay, so there is just like some type of the conditions, like we studied about the like VI POMA conditions. All these we will, I think, will discuss. Okay, for now you can remember, if any type of these questions will come, so they will ask you, they didn't give you the hyperkalemia or they can give you the hypokalemia. So both are correct. So any problem with the arrhythmia, so arrhythmia they can cause like what the abnormality or the problem, metabolic abnormality we see in these conditions. So that it can be caused by the hypokalemia conditions, and it can be caused by the hyperkalemia as well. Okay, this hypokalemia conditions we seen in case of the VI POMA. So that is VI POMA. What we will see? We will see the chronic secretory diarrhea. We see there is a chronic secretory diarrhea. Along with that, we see there is a pancreatic mass will be there. We will see there is a pancreatic mass will be there, and there will be see that there will be the hypokalemia and achlorohydria. So that we will see in case of the VI POMA. Okay, so anything like we have anything that hypokalemia or hyperkalemia, because they didn't give the more details in this question, that's why we need to just measure with the help of the arrhythmia only. And arrhythmia, there is what, that the main regions that cause the hyperkalemia. Okay, the some questions like they didn't give the proper informations, that's why we need to choose directly. Okay, if anything will be more from this type of the questions, we will discuss. So, but for now, just remember, if anemia will be there, there will be the hyperkalemia. Okay, or it may be hypokalemia. I hope every one of you know what is the hyperazotemia. What is the hyperazotemia? Decrease in sodium. The hyperazotemia, decrease in sodium. Alkalosis, acidosis, hyponatremia. I think you already discussed in your croak 1. There is, I think, no questions in the croak 2 about the metabolic alkalosis, acidosis, respiratory. I didn't show those type of the questions here because they are directly from the pathology point of view. Okay, but if we will get the times, I would love to share you the about all these topics, because these are the topics like that is very important to understand, because they need some concept. Directly we can understand, okay, this is what from croak to one point of view we can understand that this is okay, there is something like metabolic and there is a other things that is the non metabolics. ओके वो हमने एक अच्छे से तरीके से हमने उसको रिवाइज पता है हमें कि हमने कैसे उसको अच्छे से कर रखा है. रेस्पिरेटरी, अगर कार्बन डाइऑक्साइड एसिड है तो वो रेस्पिरेटरी बन जाता है. बट इफ यू गोइंग टू द लाइक एनी माउंटेन प्लेसेस तो वो क्या हो गया, दैट इज द बिकम द नॉन रेस्पिरेटरी. ठीक है, लाइक समथिंग मेटाबॉलिक और रेस्पिरेटरी. और डायरिया, अगर डायरिया वोमिटिंग वाली थिंग्स है, सो दैट विल बिकम द मेटाबॉलिक कंडीशंस और द नॉन एक्सक्रीटरी कंडीशंस. ठीक है, so these we already discussed, but whenever if you will get the times, but then we will discuss the whole topic in detail, everything, because there is something like metabolic alkalosis, respiratory alkalosis based on the bicarbonate, because there is some amount also, and believe me that is like very beautiful topic, but for that we needed times and we have the limited times. This question will not ask you in exam, that's why I am not going for now. The autoimmune thyroid, this one we already did. 138 we already did. There was a one questions about, I think one things we did not do. Did we do the celiac disease? Celiac disease or the Whipple disease? Celiac disease or the Whipple disease? I think we just did the cystic fibrosis, right? So write down the headings: malabsorption syndromes. Okay, and in the like this we having the neonatal sepsis and other infections. Also write those one line all about all those infections. So we are having the omphalitis. What we have, the omphalitis. These all are the infections that we seen in case of the neonates conditions. What is the omphalitis? Omphalitis is the inflammation of the umbilical cord. The omphalitis is the inflammation of umbilical cords. So in the omphalitis, we see there is a redness. We see there is a redness there because the inflammation. That's why the redness will be there. After that, we see there is a indurations. Pus discharge will be there. Indurations will be there. Pus discharge around the umbilicus. The pus discharge around umbilicus. So that is the omphalitis. Okay, and this omphalitis, remember, this can also lead, if there is a redness, induration, there is a pus discharge is there, and this pus can convert into the systemic infections, that is the neonatal sepsis. This omphalitis, all these omphalitis and the conjunctivitis, oral thrush, these are the superficial infections. But if we talk about the neonatal sepsis, this is the systemic infections. This is the systemic infection. So this can lead to the tonsillitis. It can lead to the sepsis. It can complicate to the sepsis. It can complicate to sepsis, and the sepsis is the systemic infections. Then other conditions that we seen in neonate, that like oral thrush. Oral thrush that we already I think discussed. Now oral thrush we didn't discuss. We discussed the chlamydia, but oral thrush, remember, it is caused by the candida. The oral thrush, it is caused by the candida species. If candida is there, so that will cause the oral thrush. So whenever we will try to wipe it out, so we have the difficulty to wipe off. Difficult to wipe off. Difficult to wipe off. Like we do in case of like the diphtheria also. So when we are difficult to, when we will take it, when we try to difficult, when we try to scrap it, so there will be the like some hemorrhagic spot will be there. There is presence of hemorrhagic spot will be there. The presence of hemorrhagic spot will be there after forceful scraping. When we do the forceful scraping, we will see there will be the like hemorrhagic spot will be there. What is the treatment we give in the case of the candida? We giving the topical nystatins. Topical nystatin. And remember that is the like very important drugs for the candida. Nystatin or topical nystatins we give in these conditions. Other we can give the clotrimazole drugs. Clotrimazole. So the nystatin is very important because whenever the candida comes, nystatin comes. The clotrimazoles. That is the clotrimazoles. There is a one more infection that we seen in this condition, that is the conjunctivitis in case of the neonates. Conjunctivitis, what is we called it this condition as the ophthalmia, ophthalmia neonatrums. The ophthalmia neonatorum. Is it congenital or acquired? So it is acquired conditions. When it will acquired? During delivery of the baby. When we are delivering the baby, so there can be the infected birth canals during the delivery of the baby along infected birth canals. So infected birth canals can lead to the conjunctivitis in these neonates. Infected birth canals. Okay, so that you can write also the headings here, the infections in neonates. You can write the heading also here, that is the infections in neonates. There is other also infections like the torch infections. Okay, the torch infections. Torch infection include like T4 we having the toxoplasma, R4 we discussed the rubella. The toxoplasma gondii we discussed in case of the croc one, and now they will not ask you this question. But the toxoplasma gondii, but the torch infection, that is a very common seen in case of the pediatric peoples, or we call it as the torch profiles. There is like toxoplasma O4, you can write it here, torch infection. Just remember the name. T4 we have the toxoplasma. These are the toxoplasma. O4 like others. O4 others. R4 rubella. R4 rubella. C4 cytomegalovirus. C4 cytomegalovirus, and H4 we are having the herpes. Cytomegalovirus, remember this is the most common infection. The most common. The cytomegalovirus is the most common infections. Okay, in the toxoplasma we have the triad. In the toxoplasma we having the triad. What is the triad we having the toxoplasma? We having the toxoplasma we having the triads. What triad we having? That is the hydrocephalus, chorioretinitis, and intracranial diffuse calcification. So first, second and third, that is the intracranial diffuse calcifications. The intracranial diffuse calcifications. This is that we having the tride. So this is the tride that we seen in case of the Toxoplasma gondii. The tride that is the Toxoplasma gondii. Rubella, you can remember one also for the one line for the rubella. We discussed already before complete rubella, but this is the most severe conditions, most severe for intrauterine infections, most severe for the intrauterine infections, the most severe for the intrauterine infections, that is what rubella. And this is rubella is also, remember, this is the dangerous in first trimester. This one you can also remember. Rubella, it is the more dangerous in first trimester, more dangerous in first trimester. I hope every one of you know what is the trimester. Trimester, we are having the three trimesters: the first trimester, second trimesters, or the third trimesters. We will discuss in the obstetrics. If you don't know, don't worry about it, we will discuss it. Okay, this is the more dangerous with the first trimester. If mother is infected with rubella, there is a high chance, like 90 to 91% chances, that children will also get the rubella syndromes. And cytomegalovirus, this is the most common infection that we seen in these conditions. And also remember, there is one more things, like we can having one more condition, that is the congenital rubella syndromes, where we discuss the congenital toxoplasma syndrome, and here we having the congenital rubella syndromes. If congenital rubella syndrome is what, that is the pyar mein andha behra. This is the mnemonics from the Dr. Preeti Sharma. That is the pyar mein andha behra. So what is the pyar mein andha behra? That is congenital heart defect. So there will be the congenital heart defect will be there, and congenital heart defect, there will be the patent ductus arteriosus will be there. After that, there will be the cataract will be seen, and there will be the deafness. Okay, now you understand प्यार में अंधा बहरा. What is that? Heart में, अगर प्यार में, that is heart में defect हुआ तो क्या हो गया? अंधा और बहरा. That is the cataract and deafness. प्यार में अंधा बहरा, that is the PDA. प्यार में अंधा बहरा. Congenital rubella syndromes. Okay, I think we are done here. और क्या रह गया? Cytomegalovirus, you already know that there is a it also causes the hand or foot mouth disease. And cytomegalovirus, you can remember, we having the owl's eye, that is the I think they will ask you for the in croc 2, not more than that they will ask. Okay, so this is what we having the like some infections associated with the neonates. After that, what we was studying? We were studying about the malabsorption syndromes. I hope this is clear, guys. Is it clear, right? You mean nitrogen for azotemia? Did I what I told? Yes, nitrogen for azotemia. I think I told you said sodium. That is hyponatremia. Okay, sorry, I'm really sorry. Sodium, you know, that is the hyponatremia, and then hyponatremia decrease in the nitrogens. Okay, that you need to remember. I think I did not write. Okay, so I hope everyone of you know already. That is, we having the hyponatremia. If the sodium level is low, we call this condition as the hyponatremia. Where was that question? That was the question number. Okay, you understand it. Make that correction. It is a like very little correction, tiny correction. Okay. So we were discussing about the malabsorption syndromes. कोई नहीं, इट्स ओके, ठीक है. Let's continue with the malabsorption syndromes. We will discuss after that. Malabsorption syndromes. See, malabsorption syndrome means the malabsorption syndrome. What happened in the malabsorption syndromes? There is a problem in having the absorptions. That is what malabsorptions. That is the clear things. See, in malabsorption, we discuss that mainly that we see that there is a digestion problem in the fat. That's why we will see that baby will be having the steatorrhea. The baby will be having the steatorrhea type of the things will be there. The things that we seen in case of the malabsorption syndrome, we see that the baby will be having like the Whipple disease, and we will be having the celiac disease will be there. So all these things will be done. Okay, that is the malabsorption syndromes. Okay, let's write it. So main, that is that there is a no absorption, we can say, or very less absorption will be, that is the malabsorption syndromes. So then remember, if we talk about the hallmark feature of that, the hallmark of the malabsorption syndromes, the hallmark will be the fat is not absorbed. The fat is not absorbed. If the fat will be not absorbed, then we call this condition as the steatorrhea. We call this condition as the steatorrhea. We call this condition as the steatorrhea. And what the steatorrhea will be looks like? There will be the bulky, frothy, foul smelling. The bulky, frothy, foul smelling. That will be the difficult to the flush. Okay, the fat will be not absorbed. That the hallmark features that we seen in case of the malabsorption syndromes. We see that there are two type of the malabsorption syndromes that in our exams, that is the Whipple disease. One we having the Whipple disease. Whipple disease, they will not ask you much. The Whipple disease, remember, that is associated with a which? Associated with, this is associated with gram positive Trophærium Whippleyi. Trophærium Whippleyi. So it is a gram positive bacteria. Whippleyi. This is a okay. Just give me. Let's take a 10 minutes break. Okay. I have some just very urgent work. Okay. Just take a 10 minutes break and we will continue. Okay, let's come back. Okay, so I will come. So we are discussing about the Whipple disease. So Whipple disease, it is associated with the gram-positive Trophilema whippli. That is the gram-positive bacteria. So it is what we will see that in this there is a foam cells and there are the macrophagic cells will be present. The foam cells or the macrophagic cells will be there. That you need to understand, and that is more than enough. Okay, for diagnosis also remember they are the pass positives, they are the pass positive cells, they are the pass positive cells, and they are Jill Nelson negative. But for now, just Whipple disease that is associated with the, you need to remember just this bacteria Topharima whipple, and there is a, these are what, past positives, and your things will be solved. After that there is a other important disease, that is the celiac disease, that is the celiac disease. What is the celiac disease? This is the important topic, not for Croc 2 but for further exams as well. The celiac disease, this is also known as the gluten sensitive. This is also known as, everybody came right? Okay. So this is also known as the gluten. This is also known as the gluten sensitive. The gluten foods, that is the sensitive enteropathy. Gluten sensitive enteropathy. So this is the gluten sensitive enteropathy will be there. That is the celiac disease. What are the gluten? The gluten foods. So that is gluten foods we having like bro. What are that? Is the bro. BROW. So what are the gluten foods? They contain the glutens. So like barley, rice, oats, and wheat. So all these contain what? They contain the gluten, right? They contain the glutens, and they contains basically alpha gliadins. They contain the alpha gliadins, and the patients will be sensitive to these diseases, sensitive to these type of the gluten foods. So they, what happen in this condition, in case of the celiac disease, there is an antibody formation. So antibody formation against the TTG, against the antibody against TTG. So there is a we will make what, anti-TTG antibody will be there. The antibody will form against the TTG. Antibody will be formed against the TTG antibody. Then it can be formed against, there is a antibody. What is the TTG full form? That is the tissue transglutaminase, IgA antibody. The IgA antibody. This is the tissue transglutaminase IgA antibody. There will be the antibody formations will be against these transglutaminase and IgA antibody. Then there is the other antibodies, that is the anti-gliadin, because we have the alpha gliadin. So there will be the anti-gliadin antibody. There will be the antibody formations against the endomysial. So there is a 3 antibody. We have the gliadin, then we having the tissue transglutaminase IgA antibody, gliadin, and endomysial antibodies. These antibodies you should remember by heart. TTG transglutaminase. You remember transglutaminase. They all three are the IgA antibody usually. Then another gliadin, endomysials, transglutaminase, gliadin, endomysials, transglutaminase, gliadin, endomysial. Very important antibodies you need to remember for the celiac disease. Okay. Then they are also, you can remember, they are associated with HLA-DQ28 polymorphisms. If you want to remember it, you can remember, otherwise you can skip it. They are also associated with dermatomyositis. They are also associated with the dermatomyositis. They are also associated with the dermatomyositis. Okay, that you know. What is the treatment you will give? Avoid gluten diet, or you can write gluten-free diet will be given. So gluten-free diets will be given to the patients. So what we will give? Gluten-free diet will be given. So gluten-free diet will be given to this patient. Okay. So this is the celiac disease, and this is very important disease that you need to remember. Okay, if you are studying about the celiac disease, then one more things you can study from here only, that there is other 2 important drugs, that is the Crohn's disease and ulcerative colitis. See, when we talk about the Crohn's disease, so Crohn's disease, you need to remember the mnemonics. Firstly, we see there is a skip lesions. You can remember the mnemonic: sister, sister, Mac. Which sister? Sister Mac. Sister Mac. So what we will see, that is the skip lesions. We will see the skip lesions. The skip lesions or the skin nodules will be seen. The skip lesions and skin nodules will be seen in case of the Crohn's disease. In case of ulcerative colitis, we see there is a continuous lesions. We will see the difference after that also. So we can see that in the Crohn's disease we are seeing the not skin lesion, skip lesion. The lesions will be skims here, then here. This is like we have the intestine, and we are seeing the lesion at the between, there is a gap will be there. Which is the most common site affected? The most common site affected is the ileum. What is that? Ileum. The most common site affected is the ileum will be most commonly site affected. In S4 we having which sign will be there? We will see there is a string sign will be affected more. What sign will be seen? That is the string sign. Which sign? String sign will be seen. If I ask you which sign is seen in the Crohn's disease, that is the string sign seen in the Crohn's disease. Then also remember T4. T4 thickness. So if you thickness, if you will see, there is a full thickness will be there. Thickness, the full thickness, or we can say the entire wall. The entire wall will be there. The entire wall will be there. And due to which there will be the like fissure or the fistula formations can be seen. Fissure or the fistula formations can be seen. Then R4, remember R form, the rectum will never be involved. So rectum will never be involved, or rectums you can remember spared. Rectum will be spared, but that is the best thing, that if you write the rectum will never be involved, because when you will write rectum spared, I know that you can forget it, but if you will write rectum will never be involved, you will never forget it. If we talk about the microscopy finding, I mean microscopy. In microscopy, we see that there is a non-caseating granuloma. We see there is a non-caseating granuloma. There will be the non-caseating granuloma. There is a one ulcer things will be seen, that is the apathous ulcers. Apathous ulcers will be seen, and apathous ulcer you need to remember, this is the first ulcers will be seen. First ulcers, when these ulcers will be progressive, if they will progress, they will form the serpiginous ulcers. This type of the serpiginous ulcers. What is the serpiginous ulcers? See, if you having this blood intestines, so we will be having this type of the ulcers will be seen in case of the like serpentine fashion. So that is the serpiginous ulcer. C is very important. The C is what? C. C means C. So C means जो तुम सी समझ रहे हो वो सी नहीं है ये, है ना. तो ये क्या है? कोबल स्टोन अपीयरेंस. ये क्या है? कोबल स्टोन अपीयरेंस. क्या है? कोबल स्टोन अपीयरेंस. Cobble stone appearance. There, what will be the like cobble stone appearance? I will share you the images. That is the, we will see the inside of the intestines. The inside of intestines, it will looks like the cobblestone. So that will give the cobblestone. Whenever the cobblestone appearance will be seen in the questions, that is what the Crohn's disease. Then we having the creeping fat. We will be having the creeping fat outside. We will see outside. If you will see the outside, it will be looks like the creeping fat. There will be the creeping fat will be there. And also remember the treatment for the Crohn's disease. What is that? Infliximab. Infliximab will be given. And this is what? Anti-TNF alpha. Why the anti-TNF alpha is given? Because they have the cytokine. They have the cytokine formations and inhibit the cytokine. Which cytokines will be cytokine formations will be there. Which cytokine formation? TNF alpha formations will be there. C for cobblestone, C for creeping fat from the outsides, and there is a cytokine formations TNF alpha. So that's why we can give the infliximab. Infliximab's anti-TNF alpha will be given. There is one disease, that is ulcerative colitis. There is one other disorder, that is the ulcerative colitis. Ulcerative colitis. So in ulcerative colitis, remember there will be the ulcers. The ulcer with there will be the pseudo polyp. We having the polyp like growth like structures. The polyp will be there. So polyp, polyp we studied, that is like juvenile polyps and Cowden syndromes. We having the Banyan syndromes, tuberous sclerosis. We see there is that is the true polyp. But here is what, that the formation of the like the growth. This growth will be the pseudo polyps. Okay, that we can say the regenerating mucosa will be there. That is the regenerating mucosa will be there. So pseudopolyp, this is seen in case of the ulcerative colitis. So colitis, so you can remember the mnemonics colitis. You can remember the mnemonics colitis. Colitis. C4 we will be having the continuous lesions. C4 will be having the continuous lesions. Then here remember in Crohn's disease what we studied? We studied that there is skip lesions. We studied here that there is a continuous lesions. If we studied in Crohn's disease, there is what, rectum will never be involved. Here in ulcerative colitis, the rectum will be most commonly affected. Often rectum will be affected. The rectum will be affected usually. And which involvement will be there? That is the retrograde involvement. Which involvement will be there? That will be the retrograde involvement. There will be the retrograde involvement will be there. L if we see, that is the lead pipe appearance. L if we see, that is the lead pipe appearance will be there. That is the most important point. See, in Crohn's disease we see there is a cobblestone appearance. In ulcerative colitis what we will be having, that is the lead pipe appearance. We will be having the lead pipe appearance. Then I4, remember we having the immunity. The I4 will be having the immunity, and immunity, that will be the P ANCA will be there. P ANCA immunity we already discussed. The P, it is associated with which condition is associated with the P ANCA. We studied that there is a microscopic with polyangiitis. Then we studied that there is a ulcerative colitis and primary sclerosing cholangitis we studied there. Then they have the complications. The complications will be having the complications. There will be the toxic megacolon. There will be the toxics. Whatever we are writing, there are very important points and very important point to understand also. I will repeat it and I will teach you. So there is an increase in the. So there is the increase on the no cancer. The increase in what? Okay, leave these things. So we have the colitis. So remember there is a no. Okay. Then as for, remember we will be having it is the smoking. It is the, as for we having the smoking protective. If anyone who is doing the smoker, if anyone is smoker, so it is the protective factor in that conditions. Okay. Here what the treatment we gives? The treatment here we gives is the 5-amino salicylic acid, 5-amino salicylic acid and 6 mercaptopurins, 6 mercaptopurins. 5-amino salicylic acid and 6 mercaptopurin. That is what? That is the treatment we given in these conditions. The treatment we give in this condition. That is what? This one. Okay, the 5-amino salicylic and the 6 mercaptopurin. Now see, we studied that there is what? Crohn's disease. In the Crohn's disease we studied that there is a skip lesion is there. There is a skip lesions and the skin nodules. In ulcerative colitis, better write it like this only. We having the skip lesion. In ulcerative colitis we studied that is the continuous lesion. Most common site here is the ileums. So you can say that it involves the Crohn's disease, it involves the whole alimentary canal or the GIT, it whole GIT. But ulcerative colitis, they only involves the rectum, mainly involve the rectum part till now. Then we have the string sign will be there. thickness full string sign that will seen in case of the X-ray or the radiological images. There will be the thickness or the we call it the transmural. We call this condition as the transmural. Like all the layers will be involved. Mucosa, submucosa, subserosa, serosa, all these layers will be involved and they will form the fissures and the fistula formations will be there. Fistula is what? That is the two-way abnormal connection will be there. The rectum will never be involved. The rectum is most commonly involved in the ulcerative colitis. Microscopy we see non-cassating granuloma, apathous ulcers that if you can skip this one, you can skip this one. Apathous ulcers you can get some keyword type of the thing, but this is the important the cobblestone appearance. We having the cobblestone appearance. We having the cobblestone appearance. Then lead pipe appearance. See, whenever there is a diffuse lesion. So the lesions it will become the lead pipe. It will become the lead pipe. Normally we having the our intestines will be looks like this. Our intestine will be look like this. But in case of ulcerative colitis, it will become the lead pipe. Like this type of appearance will be seen. And remember that if this completely like we having the rectum is involved, so the rectum if it is proceed there is a retrograde, there will be the we can call it the retrograde involvement. Firstly the rectum will be involved, after that sigmoid colon, then there will be the descending colon, transverse colon, ascending colon, everything, all the large intestines will be affected, and that we call, that's why it will become the toxic megacolon. The megacolon means the size of the intestines will become the big size. So that we called it the toxic megacolons. And also remember, this is the protective. Smoking is the protective factor in these conditions. Okay, that you need to understand. Okay. Okay, so this was all about today. Whatever topics we have remaining, so we will discuss it tomorrow. Tomorrow we will not do the some major topics, but we will try to finish the pediatrics, and whatever the topics will be left from the pedia, we will do that. And after that we will go for to the maybe obstetrics will be the best, so that we will do. Okay. I hope for till now everything is clear. Okay, thank you so much. See, अभी क्या है? Let me turn on your microphone. Post management is nothing. ECG for tomorrow. तो फिर वो पीडिया वाला नहीं होगा ना, तो एकदम से थोड़ा सा स्ट्रेस रहेगा, है ना? इस वजह से मैं आज ही करने को आज कर देता, बट जैसे एकदम पीडिया थोड़ा सा कंप्लीट हो जाएगा ना, सो वी विल गेट जस्ट रिलैक्स कि चलो यार एक सब्जेक्ट तो हो गया. दैट्स व्हाई वी विल आई डिडंट चूज द ईसीजी टुडे. ठीक है, जैसे ही वो हो जाएगा उसके बाद अपने फिर वो करेंगे. देखो, व्हेन आई वाज डूइंग क्लास से पहले, आई वाज एट दिस टाइम, क्योंकि ये थोड़ा लेट भी हो गया था तो मेरे को नींद भी आ रही थी, है ना? तो बट उसके बाद क्या हुआ कि पता नहीं क्या, जस्ट आफ्टर 5 मिनट क्लास से जस्ट 5 मिनट पहले मुझमें क्या एनर्जी आई, क्या कुछ हुआ, वट एवर आई डोंट नो, वट एवर आई फील, बट मेरे को इतना मतलब मेरे पढ़ाने का बिल्कुल मन नहीं था. ठीक है, उसके क्लास से पहले पहले, बट आफ्टर दैट आई गोट कि भाई अभी पढ़ाना है, और वो पढ़ाने पढ़ाने वो एनर्जी का जो सोर्स होता है ना, दैट केम और अचानक से आ गया वो सारा. आई वाज नॉट इन द मूड ऑफ द स्टडी. अरे यार, एक दो तीन चार, I was not in the mood of the study at before class, but whenever I joined the class, I don't know what kind of energy I got. I was like very active at that time. But before that, I was very inactive. I was completely tired today because I went for the evening walk after 6 months. You can say just I was at home only, so I didn't go for. I did 7 or 8 thousand steps today after so long, and so I was completely tired. So after that, I was not. I was thinking, "Arey yaar, this class I need to take and everything." So I want you to that every time, whenever you joining, make sure before you want to join or before you want to study, okay, before you want to self study or you wanted to join any classes. So before that, try to maintain that aura in yourself,
and try to create the positive environment in surrounding you. The main thing that can help you to clear any exams is the positivity inside you. कुछ कहते हैं ना कि पॉजिटिविटी खुद के अंदर से नहीं आती, बट बिलीव मी द पॉजिटिविटी विल कम फ्रॉम इनसाइड यू ओनली. नो वन कैन मेक यू पॉजिटिव if you will not try to will to become how much positive you can be. Try to find any reasons so that you can be positive in any circumstances, or you can be active in like other, if any important work in your life, that at that time you become the active. Otherwise, you need to be like the monkey persons who just laziness and everything will be done. But at that time, when you are having some important work, you have need to do something for your goal. You want to become a successful doctor. For that, you need to be doing work hard, and for that, you need a little motivations every day by yourself. Don't think about like what other people are saying you and all those things, but main focus should be on your target, that okay, I am doing my best, and forgive everything. Okay, and after that you can just start your whatever you have.